Good afternoon, everyone. I'm Gary Harbison. I'm the Executive Director of the Missouri Coalition for Oral Health, and it's my pleasure to welcome you to this afternoon's webinar. And with that, I'm going to hand it over to Jessica Emmerich.
Yes, thank you for joining. I know we still have a few people joining, but we're going to go ahead and kick it off. Today's webinar, Realities of Medicaid, a Model for Orthodontic Services through HealthNet, is going to be starting promptly. The Missouri Coalition for Oral Health is a 501c3 advocacy organization focused on policy and systems change to increase access to oral health services for all Missourians. You can learn more about the Missouri Coalition for Oral Health and other upcoming events by visiting our website, Facebook page, Twitter, and LinkedIn. I am Jessica Emmerich, the Dental Medicaid Facilitator with the Missouri Coalition for Oral Health. With the help of the Missouri Dental Association and HealthNet, we have been working with dental providers to increase Medicaid participation. Through that work, providers have brought to our attention several barriers that prevent them providing the necessary care for Medicaid patients. The vision and mission of the Missouri Coalition for Oral Health is oral health for all Missourians. Today we have Dr. Robert Waxler and Dr. Jeff Kavanaugh with Century Orthodontics here to share their experience with providing orthodontic services and how Medicaid works in their practice. During the webinars, attendees are muted, but you can submit questions in the chat or Q&A box, and we'll answer those at the end if time allows. The webinar is being recorded, and you will be able to find the recording on the Missouri Coalition for Oral Health website after the presentation. With that, I'm going to turn it over to Dr. Robert Waxler.
Okay, well, good afternoon, all. So a little bit about myself. Hopefully you can see the screen. This is my CV. I practiced for over 40 years orthodontics in the St. Louis area. Century Orthodontics, my partner Jeff Kavanaugh has now taken over the practice. And a couple of years ago, I retired from that, but I do run the orthodontic program at the Missouri School of Dentistry and Oral Health. So I've got quite a bit of experience in orthodontics, over 40 years. And I am also the orthodontic consultant for the Missouri HealthNet program. So I do know quite a bit about how the program is structured, and I did help to write some of the regulations. So why did I start doing Medicaid? A big part of it was just the challenge. I was kind of getting bored with regular orthodontics, especially with I was one of the first people in the country to be doing Invisalign, and I really enjoyed the challenge of Invisalign. But after a while, it was like these patients with these very minor problems needing a microscope sometimes to see what they were complaining about. And that really wasn't what I was trained for, nor what you were trained for. We are specialists in the field of orthodontics, and we should be dealing with the worst of the worst, like this patient right here. And these are the ones that I really enjoyed treating, and I think that these are probably the cases that you enjoy treating, the really severe patients. But if you're practicing in a relatively wealthy area where almost every kid gets some sort of orthodontic treatment, you don't see these patients all the time. You spend a lot of time dealing with minor problems with kids who may not even want to get treatment. So who really needs your field of expertise? It's the patient on the left, patient with a severe overjet, not the patient who's got a couple of minor little irregularities that any general dentist can go ahead and do Invisalign on. So, you know, the patients who over the last years where I've been doing Medicaid treatment, the ones who really appreciate what I was doing, where I was really changing their lives, were the patients who had these horrible disfiguring mouths. And those are the ones that were really the most rewarding and treating. Not the patients who were, you know, there just because their mom or dad said that they had to go. So a couple of things. I mean, you don't have to take a certain number of Medicaid patients. You can take as many or as few as you want. You can start out just doing a few of them just to get your feet wet. You got a little extra time in your schedule, and you can do as many or as few of those cases as you would like. What has really changed in the number of years that I've been doing it is the fees. When for 20 or plus years that I've been involved with Medicaid or doing this, the fee was $2,200. That was the maximum fee for a full set of braces. And with overhead being 60–70% of the practice, you just couldn't make money. For a long time, I was just doing Medicaid as a charity, really, because of the fees were so low. But they just recently raised the fees up to up to and around $5,000, as much or more than a lot of the managed care companies are paying for regular insurance treatments. So it is now something that you can actually make money at. So who qualifies? If you look at the bell curve of orthodontic problems, very few people have got ideal occlusions. Everybody has a malocclusion of some degree, some sort. And of course, in the real world, not the real world, but the utopian world, orthodontics would be treating all of these patients who weren't ideal. You got a minor problem one way, a minor problem the other way, and everybody needs braces because everybody is not perfect. But in Medicaid funded treatment, only the most extreme, only the worst of the worst really qualifies. So if you enjoy treating very difficult, very complex problems, patients that are disfigured, patients who look terrible, patients who really are going to appreciate your expertise, these are the patients that are going to qualify and you're going to be able to treat. So just kind of as general requirements, nowadays, almost all patients in Missouri are under one of, I think, 3 managed care programs. So they have to be enrolled in one of these managed care Medicaid programs, and you have to sign up for them. You can sign up for 1, 2, or all 3 of these programs. They must have a primary care dentist. They must be seen regularly, up to date in their treatment. You don't have to start treating these people until they're good and healthy. Good oral hygiene, and they must be willing to come and see you, okay? There's really 2 different programs that are that you can provide orthodontic treatment under the Medicaid program. The comprehensive full brace is a lot of people are familiar with that, and that is kind of an all or nothing. If they qualify, they get full brace treatment. If they don't qualify, they get nothing. But there is another way of treating more limited interceptive treatments under the Federal Early Periodic Screening, Diagnosis, and Treatment, EPSDT. That's a little bit of an unknown method, but you can do some limited treatment under that. I'm not going to talk too much about that, but you can do some early treatment under this other program. So if you're in the comprehensive field, the patient has to be 13 full set of permanent teeth, unless there are primary teeth there because of ectopic eruption or missing teeth or something like that. Or there are a few exceptions, such as cleft palate, impacted central incisor, or a few other situations. But for the most part, these patients should have a full set of permanent teeth. We're not talking about doing 2-phase interceptive treatment. These are just your typical 12, 13, 14, 15-year-old kid, full set of braces. And there is a form that you have to fill out to get approved. Now, in general, there are 3 ways to get approved. The first is what we call an automatic. So there's a list of 6 automatics. If the patient has one of these characteristics, then they are just automatically approved. So if they have a 9mm overjet or a 3.5mm underbite, it's an automatic approval. Cleft palate is an automatic approval. Deep bite with tissue damage, anterior crossbite with tissue damage. These are all automatics, and if they have one of these characteristics, you just send it in, the patient is automatically qualified. And I would say, I don't know, maybe 60% of the patients who end up getting approved are going to be one of these automatics. So this is the kind of the primary way, at least in my practice, seemed to be that they were getting approved. So here's a patient with really nothing terrible other than that anterior crossbite. There is tissue damage, and this would be an automatic approval, and actually a relatively simple case that you can make some money on a case like this, because you could get something like this treated in 4 or 5 months, and you could actually make quite a bit of money on a case like that, because it is a qualifying case. It's got anterior crossbite with tissue damage. The second way of getting approved is what's called the Handicapping Labial Lingual Deviation Index, the HLD index. And you need 28 points on this index. And there are a number of ways of getting points. The problem here is it is awfully hard to get 28 points. So you look at this patient with a very disfiguring malocclusion, and you get 5 points for upper crowding, 5 points for lower crowding, a point for every millimeter of overjet, a point for every millimeter of overbite. Labial lingual means the labial lingual discrepancy between the most labial tooth and the most lingual anterior tooth, so maybe 7 millimeters. So looking at this case, that's only 29 points. So that shows you how really bad you have to be to qualify for treatment. So these are the fun cases. I mean, I always loved cases like this because, you have some great before and after pictures, and the patient is so appreciative of what you're doing. And the third way that you can kind of get approval, and this is a way that a lot of people are really not familiar with and they miss out on it, is what we call medical necessity, which is really dental or psychological necessity. So this type of patient right here, they don't have 28 points, they don't have an automatic, but they certainly have a severe orthodontic issue that really desperately needs to be treated. Those second molars are never going to erupt. There's going to be all sorts of major consequences in the patient like this. And you can get a patient approved like this, but you do have to write up a special you have to write up a narrative explaining why it should be approved. So this is an example of a narrative that I would write up for a case like this. Is another narrative. I'm not going to read these things through. And actually in my office, we just went ahead and just wrote up a bunch of boilerplate narratives for different problems that I would consider medical necessity. And we just send those in, and hopefully you get these cases approved. So those are the 3 ways in general that you can get cases approved. And as I said, I think, 45% maybe are automatically approved because they have one of the 6 automatics. Another quarter of the patients may be, the medical necessity narrative, and the rest of the HLDs and stuff. So there are different ways to get these cases approved. The second way of getting approved is a federal regulation called the EPSDT, and it is kind of overrides Medicaid in the sense that the states are not allowed to set regulations. If it's something that's necessary for the health and development of a child, that it should be approved. And you have to write these things in on a narrative basis and get it sent in. It's a little bit tricky to do that. Anybody is interested, I can kind of work with them and show them how to do that. And we'll just skip that. So when you see these patients, and we tended to just kind of group them all and have them come in on a certain day and screen our patients who come in, because a lot of people are just not going to qualify. And this was the little thing that I did. I had a little game that I played, and even before I would actually look at the patient's mouth, I would tell the mother, I would say, you know what, before I even look at your kid's mouth, I'm going to tell you that I'm sure they've got an orthodontic problem. I'm sure they've got crooked teeth. I'm sure your dentist has already told you that your kid needs treatment. But this is an entitlement there's only so much money in the Medicaid program. Medicaid only pays for the most severe, the most difficult problems, and there's a good chance your child's not going to qualify. So I'm kind of preempting, because they're just going to immediately say, my kid needs ortho and it should be covered. And a lot of the times it's just not going to be. And, I'll tell them it's kind of a good news, bad news, is that if I reject them and I say that they're not going to get approved, well, that's the bad news. But the good news is that they don't have a horrible, terrible problem. And what mother would want their kid to have a horrible or terrible problem? So kind of preempt them and say, this is the way that the program is. It just has to be this way. So I try to cover these points and explain why they may not be approved. And it's not my decision, but it's the state and the managed care company's decision. It has to be objective. Okay. And if they don't approve, there are some alternatives. Of course, they could just come in and pay your regular fee. Of course, a lot of these Medicaid patients do not have money. There is a organization, Smiles Change Lives, that provides almost free orthodontic treatment for patients in Missouri if they've got, they don't have the type of regulations that Medicaid has. So a lot of these kids could qualify under Smiles Change Lives. So there are some alternatives that you can offer the patients if they don't qualify. This is the way that I did it when I was in practice. I just kind of tried to screen the patients and tell them, yeah, it's not even worth sending in because you're just not going to qualify. I just talked to Dr. Kavanaugh and he says, you know what, it got to be such a problem with these patients trying to explain to them that all we do nowadays is we just go automatically, just take the records and send them in. And if they get rejected, then it's not us rejecting them, it's the state or the managed care company doing it. We just pass the buck and let the state do it, and we don't have to worry about it. And the nice thing is that the managed care companies are now paying a reasonable amount of money to send in these cases, to do the screening and to take the records. So you're actually, making money even if you're not going ahead and treating the patients. So you can do it any way that you want. And finally, I am available to anybody who has any problems. If somebody wants to contact me, you've got cases that you're not sure, how to get them qualified, or you think that they should be qualified, or you're wondering how to do that. I'm happy to talk to anybody, about it. So you're free to contact me, and hopefully I can kind of steer you through some of these issues. Okay, well, that's what I've got so far. I'm going to turn it over to Dr. Kavanaugh. Jeff?
Okay.
Yeah.
Good afternoon, everyone. As Dr. Waxler was talking about, we have practiced together for many years, and like he was talking about too, we chose to start to see Medicaid patients just kind of as a public service, and to really help kids who need help, and to do some interesting things. So that was kind of the genesis of this. Towards the end of his career, he started to see more and more Medicaid patients than I was seeing more of our regular patients. But since his retirement, I've continued to treat the Medicaid kids, and this is kind of how we decided to do it, or how it's kind of evolved in our practice over the last 2 to 3 years. Jesse, you can go ahead and go forward, please. So, first step is you get a phone call. They get referred to us many different ways, from the websites, from the Medicaid dentist, but you get a phone call. And the first thing we do is just on the phone when the parent calls or the guardian, is just confirm that they're on one of the plans. It's easy. You look on the website really quickly. We gather kind of a minimum amount of information, those kinds of things, and we schedule a screening visit with the patients. The kids that we're seeing range in age from about 10 to 16 and a half. So if someone calls looking to schedule their 7-year-old, we put them off. If someone's 17, 18 for sure, we're not scheduling them just because they're going to time out while they're in treatment in their coverage. Or we found that as the kids get older and get closer to 18, some move away, some go to college, some get jobs, so it's just harder and harder to get those kids in. So we want a reasonable amount of time to get them in and get them finished. So that's the way the 16 and a half comes in. Go ahead, Jeff. So the screening appointment, it's just a quick appointment. We schedule one every 15 minutes on the days that we treat the Medicaid patients. Assistant brings the child back. They take a pan, they take a set, they take photos on every patient. Sometimes we get pans from a dentist. Depending on the quality of the pan, we can sometimes use those. If they're poor, then we'll go ahead and take a new one, just so that we've got a good pan. After the patients have all that done, then I sit with them and I do an exam. And it's just like I would do for any patient, checking inclusion, checking clarity, cross bites, impacted teeth, ectopic teeth, just all of the normal stuff. I talk with the kids a little bit, kind of get a feel for their level of excitement about treatment and just to kind of decide, who's going to be a good patient, who's brushing their teeth. We talk about hygiene. We talk about, existing caries if there is any. We look and see kind of what notes we have from the dentist about, what their thoughts are or if there's any work that still needs to be finished. At that point, then, when I'm finished with the exam, our assistants, our staff, then walk out and talk to whomever brought the child that day. So parents, grandparents, guardians, whatever the case may be, and they go through with them and talk about what happened. For me, we tell parents that this is just an information gathering appointment. I never promise anyone that they'll qualify or not. The purpose of this appointment is just to get the information that we need to fill out the HLD form and to get it sent in. So at that point, then I sit and fill out the forms, go through treatment plans, and we get things sent in. Then you can go ahead and switch, Jeff, please. So the HLD score, which Dr. Rosso already kind of spoke about, you have time to 28 or more points to qualify. That can be a challenge with a lot of these kids, just because you don't get anything for being class 1, basically. So you have to have a lot of overjet, a lot of crowding, crossbite. So most of the kids are going to qualify in those automatic qualifiers. The carpet, deep impinging bite, crossbite, the overjet greater than 9 millimeters, the negative overjet greater than 3.5 millimeters, the impacted maxillary central incisor. I did include on here the medical necessity. Probably the one thing that happens that gets approved under medical necessity are things that are really obvious, like the ectopic second molars that Dr. Wexler showed on his pan, impacted canines, maxillary canines. Most of the time will get qualified as medically necessary. I have found that doing what's called a peer-to-peer phone call with one of the evaluating orthodontists is how I get things through that will get denied initially. We'll wait till we have 2 or 3 of those kids who've been denied, but they have kind of a more significant problem or something that I think should be treated. and we schedule a phone call with one of the orthodontists from the managed care companies, and he and I will talk about the patient. And my success rate with those is about 50-50. You know, about 50% of those kids we can get approved. Then from that point, then we go to the other options like Dr. Reisler was talking about. The Smiles Change Lives, or just staying with us, or maybe even trying to find an orthodontist for them closer to home. Go ahead, Jessica. All right, so we treat the Medicaid kids on Tuesdays, and we do 3 half days per month. So 1 month we do 2 mornings and 1 afternoon. The next month we do 1 morning and 2 afternoons. We try to do afternoons and mornings just to give parents, grandparents, again, just some variety on when we can see them, give them some flexibility. We do stick pretty hard and fast to the Tuesdays. In some extenuating circumstances, we'll see the kids on other days, but we try to keep them all on the same day, just to kind of keep things simple. They are full days, they're full half days. We see a lot of kids on these days at these times. Shows, we have some lateness, we have people arriving early. The schedule is a little more discombobulated than another day, but it always seems to work out just fine. We get everybody taken care of. You know, the ones who come late kind of even out with the ones who come early, and the number of cancellations can be variable. The number of no-shows can be variable, but really, in the way we got it set up, you don't notice the variation too much, because there's still plenty of kids to see, plenty of treatment to do. You can go ahead and switch over, please. All right, so like Dr. Reisler was saying, there's 3 plans. We participate in 2 of them: Home State and then United Healthcare. Most of our kids are Home State kids with just a few United Healthcare kids. And that's it. I knew Dr. Reisler would have more to say than me, so I didn't have quite as much. Just to kind of summarize things, I enjoy the Medicaid days. Medicaid half days. The kids are really, for the most part, super appreciative. They tell good stories. We have a lot of fun. It's a good time, and I get a lot of satisfaction from it, and I think our staff does too.
Yeah, this has been wonderful information. Thank you for sharing all that and putting those presentations together for us. We are going to go ahead and open up for question and answers. Again, you can put those questions either in the Q&A box or the chat box, and we will ask those questions out loud and give Dr. Kavanaugh and Dr. Wexler an opportunity to respond. We already have one question that has come in. Do you bill a separate code for the removal and retainers?
That's a very good question that I do not know the answer to. I think the ladies up front in our office talk about like continuation of care as how they bill this. So I'm not sure if there's a special code or if there's something they're doing differently at the end, or if it's a continuation of care code and they just put the fee in for the removal and the retainers then at that point. I didn't anticipate that question, so I apologize that I don't know the answer to it.
That's okay. And if with any of these, if we're not able to answer them, please feel free to follow up with me afterwards, and we can work with HealthNet or the managed care plans to make sure we get answers to anything we're not able to answer today. Okay, we have some comments in the chat box. This has been a great presentation. It says our biggest struggle is getting orthodontists to take Medicaid. Hopefully more people will step up. Does the payment differ if we use clear aligners to achieve goals?
We are not using any clear aligners on these patients. This is all braces.
Great. Okay, so continue to submit those questions in the Q&A or the chat box. Going back to the comment about getting orthodontists to take Medicaid, can either of you speak to any experiences or any reasons why, especially now, especially with these kiddos in need, kind of just speak to that, how to get more orthodontists on board? What information do they need to know to get them started? Any reasons to accept Medicaid?
Yeah, I think, there's just a lot of misunderstanding about how the program runs, that it's a government program and it's very, very complicated and it's very confusing and you get pimped around. And, just like anything else, there is a learning curve, and you do have to know, how to submit things, and you have to know how to structure your practice to handle it. But once you've got the system in place, it can run very, very smoothly. And the other big issue is that the fees are just so much better than what they used to be, that it is, I think I got into it because I was at a point in my career where money wasn't all that important anymore. I had been practicing for a long time, and I wasn't worried about making my house payment and everything else. And my kids had gone through college. And so I didn't mind taking a little bit of a hit by treating at a much lower rate. But the new fees are really pretty comparable to what you're going to get with a lot of the insurance programs out there.
All right, another question in the chat. Oh, sorry, go ahead.
The one thing I was going to say is, for us, we try to get a feel for the patient and the family when they come in. Yes, there are issues with kids coming to appointments, with having reliable transportation, those types of things. So that's part of choosing patients to a certain extent. We don't have to accept everybody. Some kids will ask them to come back, work on their brushing for a few months, ask them to come back, and then we check them again. We have conversations with families about, do you understand that this is a 2-year commitment, and we're going to ask you to come every month, and it's going to be important for the care of your child that you maintain that commitment. So that's part of it too. And I think in the beginning we were maybe sometimes afraid to have some of those conversations, but not as much anymore. I think for me, trying to decide when's it in the child's best interest to stop, the end treatment. If they make 4 visits in 18 months and you're starting to see decalcification, that's not a long-term benefit for that child. We just need to accept that we have, take the braces off, and if I don't get paid, then I don't get paid. But I'm more interested in the long-term health of their teeth than whether or not they're straight, whether or not I'm getting my full $4,800. So some of that, just for me and my wanting to be a perfectionist, that has to sometimes come into consideration too. So you do make different decisions sometimes, or you think a little bit differently when treating these kids, but for the most part they're the same as everybody else. They do have more difficult problems, but like I said, it's very satisfying.
Great. Okay, are orthodontic programs within the state of Missouri accepting Medicaid to your knowledge?
Just to intervene here for a second, Dr. Kavanaugh, I think it might be good if you shut your video off. We're having some jitteriness, including some of the dialogue, and it'll allow for the bandwidth a little bit better, I think. Thank you. Sorry to ask you to do that.
Oh, no problem.
Okay, so the question was, are orthodontic programs within the state of Missouri accepting Medicaid to your knowledge?
I'm not sure what you mean by orthodontic. I'm not sure what the question is. I mean, there are three managed care programs that if the child is enrolled in one of these programs, then they are covered.
Yeah. And if you are needing information about orthodontists who are enrolled with Medicaid in your area, there is a provider search on the HealthNet website that you can use to look those up, or you can reach out to me and I can help you connect with an orthodontist in your area that does accept Medicaid. If you know orthodontists in your area that are not enrolled in Medicaid, please let me know, and I'm more than happy to reach out to them as well to help answer any questions they might have.
None of the residencies programs, to my knowledge, are accepting Medicaid.
Okay, how would you recommend to go about transferring cases from other states that were previously covered by Medicaid?
Ooh, that's a good question. That can be a challenge sometimes. We've been doing this now for a while, but we have contacts with the different managed care programs. We have people that we can reach out to. Most of the time, we don't get very good coverage at all, and we end up seeing those kids and treating them and doing it basically for nothing. Again, going into this, you gotta have to kind of know that that's going to sometimes happen. One policy that we did make along the way is that we would not accept transfer patients from in town. We encourage patients, families to go back to who they were seeing and work out whatever the issues were. That we didn't want to get involved or get in the middle of those issues.
Okay. What can the state do to improve the current stringent qualifications for ortho? I've spoken with orthodontists who accept Medicaid but can't find patients who will qualify.
Unfortunately, each managed care company makes their own, has their own interpretation of the regulations. And in the past, I've tried to expand the criteria. I tried to get all impactions covered. Of course, it would be nice if we could lower the 28 points to 26 or 25. Different states have different criteria, how many points on the HLD qualify. I think a lot of it is that people are not aware of the medical necessity, and they think that if they can't come up with 28 points or they can't come up with an automatic, then the patient just doesn't qualify. And there are quite a few cases that you can make a legitimate case for medical necessity that are not covered under the automatics or the 28 points. And if you make a good case, you write up a good narrative, those should be covered. And if they still get turned down, there is something called the fair hearing where the patient can appeal and get covered. And I actually end up testifying. They contact me if a case has been rejected. And if I get a number of these cases rejected, then I can get in touch with the managed care company and try to explain that they really should be, should be covered under the medical necessity issue. It's like a lot of things in insurance. The insurance company saves money if the first thing they do is just reject it. And so if you get rejected and then you forget about it, the insurance company just makes their money. So sometimes you have to make a little bit of a stink and have to work at it a little bit, and you can get some of these cases approved.
Yeah, we had a really good question here in the question answer box. How do you handle cases where the patient loses coverage mid-treatment?
Another very good question. So up until recently with the HealthNet, in our contract, we would put that the parent was then responsible for picking up where they left off, and it's a big catch-22 because there's families that work really very hard to get off Medicaid, but then they're penalized because they do. So we would talk about they're being responsible for the remaining balance, and then we would just take those on a case by case situation. We had some people who never pay us, and then we had others who would pay what they could, $25 a month, $50 a month, to get it paid off. I think a bigger challenge is those who kept going on and on. 1 month they would be on the program, and then they would be off for 2 months, and then they would be back on the program. So that was harder because then you have to resubmit and get reapproved for them. Now that HealthNet is doing the one-time payment at the beginning, we haven't not changed recently, like within the last 3 months. We haven't had any issues, or it hasn't come up yet about getting that removal fee. If that happens, chances are we'll ask for the removal fee from the family. But if we don't get it, I'm not gonna be terribly upset if I don't get the $407. So, but that's a good question.
Yeah. Okay, does Medicaid have the same payment fee for general dentistry treating malocclusion?
Yes. But I would say, if there are orthodontists listening in here, that in general, by definition, these are the worst of the worst orthodontic problems. And if any orthodontic case should be treated by a specialist, it is these types of patients. And one of the frustrations in the past was that because the fees were so low, a lot of orthodontists did not want to treat these patients. And by default, a lot of general dentists were doing very complex orthodontic cases that they really shouldn't have been trying to do. So if you feel that difficult orthodontic cases should certainly be treated by orthodontists, then you really need to, if you're an orthodontist, you really need to participate in the program, because if you don't, then by default, you're going to end up with poorly trained general dentists doing cases that they really have no business doing.
Good information. Okay, and then Dr. Wexler, just to follow up, there was a question, what do you mean by testify when appealing a case?
Well, anybody who is in Medicaid, if they are rejected from a particular treatment, they are entitled to appeal that rejection. Now, the first thing you do is you appeal directly to the company, and hopefully that gets resolved. But if the managed care company gives you a final rejection, the patient is allowed to go into the court system and actually appeal the rejection. So if it does get to that point, then I get involved, because I end up as an expert witness in that type of appeals. So the managed care company may say, well, that's not a medical necessity, and I will look at it and I might say, well, yes, I really think it is. So at the end of the day, I can give the final 2 cents worth and whether the case should be approved or not.
Yeah, great information. There's been a lot of good discussion, a lot of good questions. We still have a little bit of time left. If anyone listening has questions, please feel free to go ahead and submit those. We want to make sure we take the time to answer any questions that are out there. We know that orthodontics is a little bit trickier cases, and we want to make sure that we give you the opportunity to ask any questions you might have. Gary has just shared the link to the post-session survey. We really appreciate your feedback after these webinars. It helps us to know what other types of trainings or if this was helpful to you. So please take your time and do that survey. We'll also send that out by email about an hour after the webinar. There was a question if we could email the slides. The recording will be on our website. If it's okay with Dr. Wexler and Dr. Kavanaugh, we can include the PowerPoints as well.
Sure.
Sure.
Great. There's a lot of good information in those, a lot of good resources to get that information out there. All right, any other questions? We're gonna give everyone one last chance while we have these two experts on the phone, or sorry, on the webinar. Well, what separates Missouri from a state that widely provides ortho like Wisconsin? Is it funding or regulation?
Well, it is kind of both. Years ago, when we were rewriting the regulations, I wanted to include any impacted tooth as an automatic qualifier. And the first thing that I was asked was how many cases would that increase the number of cases. And so that's why it ended up as only an impacted central incisor. So there's the state government, the legislature sets aside how much money is available to the program. And if you make the criteria too easy, then the numbers blow up. As a matter of fact, a few years ago, the state of Texas did not have somebody like myself to kind of help supervise the which cases should be approved and which cases shouldn't. And the state of Texas was spending more money on orthodontic treatment than the other 49 states combined. It was like $1 billion. I don't even know what it was. So it is kind of a balancing act between how much the state government apportions. If the state government was willing to put more money into the system, then we could loosen the regulations. But loosening the regulations without having the money is just not possible.
A great question. A lot of good discussion. Based off your experience working with Medicaid, in your opinion, what do you think some insurances are harder to get approved by? In your opinion, do you think some insurances are harder to get approved by?
The two companies we work with both use the same HLD form. The third company, it's Blue Access, or I'm not exactly sure what the name is. It's Blue something. The reason that we don't participate with them has more to do with how they handle submissions of claims and payment, and we had issues with them in the past. So that's why we choose not to work with them. We have found that we get plenty of patients from the two other programs, and it's gone well. So we've stuck with them. I don't know if that answers the question or not.
Yeah, I mean, legally, they're supposed to follow the state regulations, the 28 points, the automatics. The problem comes down to this medical necessity, and that is a very subjective thing. It's very hard to define. One person may say that it's medically, necessary to deal with a certain problem, and another dentist may not feel the same way. So, in that way, the insurance companies can differ. But if you've got a case that's 30 points, both sides will, all managed care companies are supposed to pay for it.
Great, good information. And if you ever have questions or issues or unsure about something, please feel free to reach out to me or reach out to HealthNet. We can help you make sure that information is correct with the managed care plans. We want to make sure you guys are getting paid for the services you're providing and that these kiddos are getting the care that they need. You mentioned medical necessity could be related to psychological issues. What is an example of that? Such as if the patient has anxiety related to it?
Okay, well, that's a good question. The problem here is that we as dentists are not legally allowed to make psychological evaluations of patients. So if a mother brings her kid in and says, all the kids at school are making fun of him and he's having all sorts of emotional issues and stuff, and that's why he needs to get his teeth straight. As a orthodontist, as a dentist, we are not qualified to make that ruling. So they would need to get a letter from a child psychologist to document that. So if they had a letter from a child psychologist stating that psychological problems were resulting from the patient's teeth and stuff, then that would fall under medical necessity. But you as a dentist cannot make that call. We're just not allowed to make that call.
Yeah, we've had a decent number of parents make that claim, but we've only had one parent kind of follow through, and she worked really, very hard to get coverage for her child. So that doesn't happen very often at all.
Great information. Thank you, guys. All right, we have just a few minutes left. Any other questions? I'm going to go ahead and take a minute and thank Dr. Waxler and Dr. Kavanaugh for being here today. We really appreciate this information and getting these resources out there to increase access to care. All right, well, not seeing any other questions. If you think of questions later, please feel free to follow up with any of us. Dr. Waxler and Dr. Kavanaugh did include their contact information on their slides. Again, there's a post-session survey. We would really appreciate your feedback if you would take the time to do that. If you have any other questions related to Missouri Medicaid or needed more information, please feel free to reach out to me directly, and I am happy to help talk to other orthodontists in your area who may not be accepting Medicaid. Please feel free to pass my information along, and I am happy to reach out to them and answer any questions they might have. So with that, we are going to go ahead and wrap up today's session. Thank you all for joining us today, and we look forward to seeing you at our next webinars. Thanks, guys.
All right, well, thank you.
Jessica.
Yes,
thank you. Dr. Waxler, can you stay on for just